Hello, change. Hello, change baby day out there with just mine. Namaya, Sunny Tintuama, Royal College of TP, Mapi Gama. The webinar, Royal College of GP, Royal College of Physicians, Burma Skin Initiative, Burma Association of General Practice, where we looked at how. So good to know, Dr. Suma, Burma Skincare Initiative for everyone. Over to you, Sue.
Jesu Demarishin, Chamaname Sumalima, Chamaga dermatology trainee for St. John's Institute of Dermatology, guys in St. Thomas Mashibare, now Birojama Research School, King's College, London, Lilo Barishin. So if I may invite Professor Chris Griffiths now to introduce kindly Dr. Ed Wilkins for today's talk. So Professor Chris Griffiths, as most of you know, he's one of the top dermatologists in the world. He is also the editor-in-chief of the Rook's textbook of dermatology, the Bible that we all have to study in order to pass our exams. And he is currently adjunct professor at King's College London and emeritus professor at the University of Manchester. So Chris, it's really, and of course he is the co-founder of the Burma Skincare Initiative, and I have the privilege to co-found the charity with him. So Chris, the floor is yours.
Okay, well, thank you very much, Sue, and thank you again, Sonny, for incorporating dermatology into the course. I'm delighted that we're able to do that. So it's my great pleasure today to introduce our speaker. It's Dr. Ed Wilkins, and Dr. Wilkins is infectious disease, or he was an infectious disease physician and head of the HIV Centre at the North Manchester General Hospital. So he was a colleague of mine in Manchester. He trained in infectious diseases in London and Liverpool, and then in tropical medicine in Africa, and has a particular expertise in HIV. And I think one of the great achievements was to set up, I think, the HIV Centre in Manchester. And he has a long and distinguished career and particular interest in Myanmar. In fact, he actually produced a weekly, very entertaining blog of his time in Yangon, I think in 2018-19, before the pandemic. And I would encourage all of you to read that, because it was his on-the-ground experiences of living in Yangon and working there. But today he's going to speak to us about his sort of specialist expertise in infectious diseases, but particularly dermatoses associated with HIV and STI infections. So over to you, Ed, and thanks again for participating today, particularly as I know it's a very busy time for you at the moment.
Well, thank you very much, Chris. And I apologise for two things. One, I'm just recovering from sore throat, so I've got a very husky voice. And the second is I have empty shelves around me and packing boxes around me, and that's because I'm moving house tomorrow. So please accept my apologies on that. Now, Chris has quite rightly said, I'm not a dermatologist and skin specialist. I am an HIV specialist. And of course, you have to learn about STI as part of that. And what I want to focus on today are rashes. And with regard to STI, I don't really want to talk about any STI classic presentations, genital discharge, ulcers. I want to talk about when you examine the skin and you find some spots, what actually they may indicate as a sexually transmitted infection. And that's outside of HIV. Now, there are far too many slides here, and it's not advancing for some reason. There we go. And therefore, I'm going to skip through some. You're going to be much better at treating a lot of dermatological conditions, because many of them are the same as you get in non-HIV patients. And so I think I'll leave that aside. But my objective today is to remind you of the rashes you know, and maybe introduce you to some new ones, such as monkeypox. To raise your index of suspicion of HIV as a possible cause of an underlying underlying HIV as possible cause of a skin rash, and such as herpes zoster, such as seborrheic dermatitis, and of course Kaposi's sarcoma. To enable you to spot a systemic condition which needs immediate diagnosis and treatment. And what I'm talking about here are the Cryptococcus, what used to be called penicilliosis and is now talaromycosis, and bacillary angiomatosis, and other very nasty conditions which need to be picked up straight away. And to review the impact of ART, antiretroviral therapy, on skin disease. And this split into two: skin rashes as a result of an antiretroviral drug, and the effect of immune reconstitution. So as a generalization, most rashes are common rashes and not specific for HIV. Most rashes are worse, especially as the CD4 count drops. More than one skin pathology often coexists, and I've mentioned herpes zoster, KS, seborrheic dermatitis, actinium. They may all coexist in a patient. Presentation may be atypical, so scabies isn't your typical scabies, but in an adult, you may get crusted, very heavy infestation with scabies, and also of the face, which is very unusual. Diagnosis is often more difficult and conditions often harder to treat. And surprisingly, not all rashes improve despite successful ART. So, you know, pleuristic papular eruption, nodular prurigo, very dry skin you get in HIV, all these incredibly itchy conditions quite often don't improve at all. Although new spots will stop arriving, you still have the original sort of papules and pigmentation and scars. Some skin diseases can develop with ART, and the classic example is psoriasis, which can first present after you start antiretroviral therapy. And some may worsen as a result of ART, and that is usually immune reconstitution that is occurring. Always examine the entire skin. Well, this is standard practice for all you skin specialists and primary care physicians. But importantly, investigate those who are unwell with a low CD4 count or an odd rash, as it may indicate a severe infection such as aromycosis or histoplasmosis. Now you can link the CD4 count to a particular skin rash. Aside of the seroconversion rash when somebody is infected for the first time, and that occurs in about 60 to 80% of patients, but it's much easier to see in a lighter skin. When you have herpes zoster or shingles, it usually indicates the CD4 count is under 350. When you get seborrheic dermatitis and tinea, which is more severe than you normally see, that again indicates a degree of impaired immunity. But when you get widespread molluscum or pruritic papular eruption, the CD4 count invariably has dropped to 200. And of course, Cryptococcal, penicilliosis, giant mollusca all indicate very low CD4 count. And visceral KS, cutaneous lymphoma, is under 50. So primary HIV seroconversion usually gives you a rash, but it's faint, it's a macular papular rash, but it's associated with an illness of fever, muscle pains, sore throat, and lymphadenopathy. Main differential diagnosis is secondary syphilis, and of course, glandular fever. The treatment, well, early ART is now given to anyone you diagnose with HIV, but it should make you do an HIV test seeing somebody with this rash. It can occasionally lead to complications, meningitis, encephalitis, anything really. And sometimes, I mean, symptomatic treatment is part and parcel of treating this condition. So first I want to talk about skin diseases which occur in patients without HIV as well. that are more frequent and often more severe in HIV, but have no identified infection basis. So xerosis of the skin, when you see very scaly skin, very dry and incredibly itchy, and it's something that patients complain about invariably, and it doesn't improve with HIV treatment as a rule. Dryness, crusting leads to scarring and ulcers. Treatment is difficult and it's just really keratolytic, salicylic acid and urea-based treatments, emollients and antihistamines. Pruritic papular eruption, nobody quite knows what it's due to. It's probably an immune response to various insect bites. But again, these start as papules or plaques, and then with the itching, they leave nodules and post-inflammatory hyperpigmentation. The picture right bottom is a good example of somebody whose CD4 count has responded, but is left with that slightly disfiguring rash, which is not going to get any better with a higher CD4 count. It's sometimes, in Africa especially, it can be the initial presentation in up to half the patients seen. Nodular prurigo I found very difficult to diagnose. The thing about this, it tends to occur in patients with lower CD4 counts, and there is no systemic illness. One often biopsies it, but the patient is otherwise well. The pathology of it is unusual. It seems to be, you see an increase in mast cells and nerve cells, but there is no identified cause, and treatments are standard treatments that you often give. Psoriasis is more frequent and often more severe, especially when your CD4 count falls. You may get new onset with the diagnosis of HIV, or it may worsen when you start treatment, and it's a type of immune reconstitution. It's more difficult to manage, and especially if your CD4 count is very low, you may have to use methotrexate or phototherapy because topical steroids are not going to be a benefit. Photosensitive rashes, again, are more common. Quite why that is, I don't think anybody realizes. Patients are often on sensitizing drugs, especially Cetrin or cotrimoxazole. ART doesn't really have an effect on improving this, but of course it's standard treatments. What about those that have a multifactorial etiology, but including infection? So if you have itchy folliculitis, it's thought that much of this is overgrowth of fungus, Malassezia furfur, and it often responds to an antifungal or antifungal combined with a steroid like Chancroid, as well as antihistamines. It has a variable response to ART, but as a rule, it gets much better. It's an early indicator of HIV, and it's one of the commonest problems. As is seborrheic dermatitis, which nearly all patients have. Not as bad as in the top picture here, which under the axilla is nearly always in the nasolabial folds, sometimes in the eyebrows, but it occurs in up to 85% of patients. And you can see here, more severe in the top picture and an annular form of it in the lower picture. But a combination of antifungal treatment with some hydrocortisone is normally, it normally improves it. And of course, antiretroviral therapy makes it significantly better. Eosinophilic folliculitis, without a biopsy, it's difficult to diagnose. It's always itchy. Going on the face, neck, scalp, and torso. Now, some of you more specialists than me may be able to identify this clinically, but I never can. And it's usually because of an unresolved rash, which you eventually biopsy, and it comes back with pathology showing eosinophilic folliculitis. The etiology is uncertain, but it's thought that Pityrosporum and bacteria may be involved. Treatment, antihistamines, itraconazole if severe, but also metronidazole for 2 weeks may be worth trying. And then there are a whole litany of other conditions which you see in HIV more frequently, which I'm not going to go into now. Then you've got those that are resulting from identifiable infections. I'm going to skip through staphylococcal skin infections because you've all seen them, but they are more frequent in HIV. Ciliary angiomatosis may not be a condition you're all familiar with, and this is picked up quite often because you have a single spot which you think is Kaposi's sarcoma. It's a bacterial infection due to Bartonella, and it's relatively straightforward to treat. It's diagnosing it that's the problem, and you can only diagnose it with a particular stain, a Wharton starry stain, but it's absolutely pathognomic. You get either nodules or you get these little spots, which are the ones that fleshy granulomatous spots, which are the ones that are often mistaken for Kaposi's sarcoma. So a single KS spot, really you should consider the differential to include bacillary angiomatosis. As I say, it's easily treatable with azithromycin or doxycycline. Scabies can be very heavy, and you can get this crusted scabies, otherwise known as Norwegian scabies. Uniquely, the face and neck may be affected. Standard treatments, but when you get this crusted scabies, you often have to use a drug called ivermectin, which is very effective in treating it. Of course, that improves with antiretroviral therapy as well. Molluscum is one of the most satisfying rashes to treat with antiretroviral therapy. It's normally just a few spots, but when you have somebody who has a low CD4 count, especially if they're a child, you can get enormous numbers of spots. And when their CD4 count is very low, and especially when they're children, you can get these giant mollusca. And the treatment is antiretroviral therapy, and the girl at the top and the girl at the bottom are the same girl. So you can see the dramatic improvement that occurs. Varicella zoster, well, you all know about this, but it may be the first clue to HIV. It can occur anywhere, and treatment is acyclovir. But the key thing in patients with low CD4 counts, it may be multi-dermatomal. So one dermatome on one side and then another dermatome on the other side. Or you may have one dermatome and then have lots of spots, like a chickenpox rash elsewhere. The eruption may be bullous, hemorrhagic, or necrotic. You get blisters and crusts, and you can see scarring in that picture. And it does occur as ARIS, somebody who has no evidence of herpes zoster 6 to 8 weeks after starting antiretroviral therapy may develop herpes zoster. Tinea, well, tinea is just more severe. And if you see bad tinea, especially of the feet, then, sorry, that went onwards, then you should consider HIV as an underlying reason why that's occurred. It's quite often harder to treat, but that's more because there's more of it. And the treatment, as is normally the case, topical antifungals, itraconazole if severe, but if you have access to terbinafine, then that would be the drug of choice. Herpes simplex, well, of course, herpes simplex is normally orogenital or wherever it is on a finger. I'm sorry about this. But in patients with very low CD4 counts, you get very unusual presentations, as you can see in these two pictures, maybe very granulomatous and ulcerated. What does happen is that this definitely gets much improved with HIV treatment, but you don't get rid of the recurrences, which always occur in the same place. But when you have an infection looking like this, you're going to need, if you can, not only to give high dose acyclovir, but intravenous acyclovir, if you have access to it. Human papillomavirus, well, it's just more severe. And I think it's as simple as that. Treatment is more difficult, but it's the same treatment as you would normally use. Importantly, opportunistic infections, cryptococcal disease, you get this generalized vesicular rash, usually over the face, neck, and upper torso. The patient will be on testing cryptococcal antigen positive. It's vital you do an LP, but quite a lot of them have meningitis as well. Even when there's no cells in the CSF, you must do a cryptococcal antigen test, and if you can, culture it. Treatment is amphotericin and fluconazole for 1 week. If you don't have flucytosine, but if you do have flucytosine, then amphotericin and flucytosine is preferable, and then followed by fluconazole 9 weeks to complete 10 weeks treatment. You delay ART for 3 to 4 weeks with cryptococcal disease because of the CNS problems, which can get worse if you start earlier. And the prophylaxis is fluconazole, but you can discontinue this once the CD4 count is above 200 and your virus is controlled. Talaromycosis or penicilliosis, again, very similar sort of rash. It's not infrequent in Myanmar. Certainly I saw quite a few cases when I was working in Yangon. The rash always indicates disseminated infection. Your slit skin smear shows characteristic yeasts with a split down the middle. Skin and blood cultures are positive. Again, amphotericin is the cornerstone of treatment, followed by itraconazole. And the same rules about discontinuing the itraconazole exist as they do for fluconazole in patients with cryptococcus. CMV, always think about CMV if you have a chronic ulcer in somebody with late stage HIV, and it will be picked up on biopsy. Treatment, valganciclovir, but antiretroviral therapy is key to get the CD4 count up. Histoplasmosis is another infection that can occur in Myanmar. It's not so common, but I've seen it. And it's a similar sort of rash, but less particular. Again, fever, sweats, weight loss. Quite often you get chest signs, a rash in up to a half, and hepatosplenomegaly. Diagnosis, again, slit skin smear. If you can do an antigen test, then do an antigen test. Amphotericin and itraconazole this time, a duration of 12 weeks, and ART initiated at 2 to 3 weeks. But the picture you see there is somebody who had histoplasma, whose rash was improving, and after starting antiretroviral therapy, then developed virus, as you can see. Prophylactic rules of stopping itraconazole, again, the same. Mycobacterial infections, well, these are rare. They can cause a sort of virtually petechial papular reaction, like you can see at the top picture, or an ulcer in the middle picture, and a biopsy will show that you've got acid-fast bacilli throughout the skin. Malignancies, well, the key one is Kaposi's sarcoma that affects the skin. Much greater frequency in HIV, and ever since ART has been introduced, the number of new cases of KS has dropped significantly. It's nowhere near as common in Myanmar, but it's presents as purple, non-tender, non-pruritic papules. It may be aggressive or it may be quite indolent, and often associated with edema and lymphadenopathy surrounding it. You get visceral KS with lesions in the stomach, which is that inset top picture, and you can get a primary pleural effusion in the lower inset picture, whereas a disseminated KS on the right there, and a localized patch. 75% of patients get better with just antiretroviral therapy. Those with visceral disease require chemotherapy, and those with extensive skin disease can improve with radiotherapy. Other cutaneous malignancies, well, not much to worry about here. Lymphoma, B or T cell can give you a nasty ulcer, like you can see there. Basal cell carcinoma and melanoma, no greater frequency, but squamous cell carcinoma is more frequent and more severe in HIV. Drug reactions, well, classically nevarapine, efavirenz, abacavir. Then you've got the drugs such as cotrimoxazole. Usually it's a macular papular rash, but it can be severe, and patients can present with Stevens-Johnson syndrome or generalized erythema, erythroderma. You need to withdraw the drug. It can be a medical emergency with Stevens-Johnson with fluid temperature control. And so if you can get a patient to hospital, it's best they're looked after in hospital. Lipodystrophy, everybody will have seen who's been around for some time looking after patients with HIV. Due to the old drugs, zidovudine, D4T and DDI, and it was due to mitochondrial toxicity. It's associated with fat accumulation on the neck and abdomen, lactic acidosis and peripheral neuropathy, and it's treated by switching drugs. I'm not going to spend time here. There's a lot to get through, but our skin conditions can flare up with all these conditions, and also on non-infectious conditions such as psoriasis, which I mentioned, and such as Kaposi sarcoma. How to investigate? Well, it really depends in what setting. If you're in an NGO clinic and you have very little you can do, then you're probably not going to be able to culture, but you can certainly do a slit skin smear or a biopsy and get it sent somewhere for examination. Just remember that there's no point just continuing with the course of treatment if there's no response. And remember that hydrocortisone can mask other conditions. I find that photographing for future reference is of great benefit, and everybody has a smartphone now. And as I said before, somebody is sick and they have a rash, you need to do a slit skin smear to exclude Cryptococcus, penicilliosis, histoplasmosis, and if need be, refer for a biopsy. If that's negative, consider empirical amphotericin while you're waiting for the result. These four have different conditions. One has penicilliosis, one has histoplasmosis, one has bacillary angiomatosis, and the other has Cryptococcus. And really, I've only cut out little bits so that you get the idea. But it's important to biopsy rashes or take a specimen of rashes when you're not certain what it's due to. What to treat with in an NGO setting? Well, it's no different from non-HIV patients where you know what you're treating, then treat it. The scabies, seborrheic dermatitis, syphilis. If uncertain and itchy, well, give emollients if it's dry, give an antihistamine, get them to cut the nails down. But for most, you try an antifungal, and if that doesn't work, you add in some hydrocortisone cream. And sorry for those who work in a much more scientific setting, but this is the practicalities of working in an NGO clinic in Myanmar. So if the syphilis screen is positive, then you follow the local guidelines, depending on whether it's primary, secondary. If low CD4 count, multiple lesions and negative cryptococcal antigen, it's likely to be, in Myanmar, it's likely to be penicilliosis, and you need to start amphotericin treatment. And if skin fungal and severe with no improvement on buconazole, then you can try triconazole. If it's crusted scabies, then you need to, if you can get hold of it, use ivermectin. So that's the first part of my talk, and I hope I'm still in time. I'm now going to move on to STI infections. I have to give you just a little bit about basic epidemiology, but then I just want to remind you of the skin, hair, nail presentations of STIs due to the highly prevalent diseases, that's excluding HIV, but gonorrhea, syphilis, and chlamydia, and then the uncommon rare tropical STIs, some of which are increasing in frequency again, mainly as a result of COVID, such as Chancroid and LGV. Then just look at the non-genital presentations that you might find on examinations, such as a bubo or conjunctivitis or arthritis, when you're doing your general examination, and briefly update you on monkeypox. So STIs are common, but nowhere near as common as they used to be because of successful control programs throughout Myanmar. There have been challenges recently because of COVID and disruption to services. And there are no recent figures from Myanmar that I have access to. Most important are gonorrhea, chlamydia, syphilis, and HIV. And the others rarely cause severe disease, such as scabies and radiculosis. Tropical STIs, as I mentioned, are making a comeback, and so it's important just to show you some of the rashes associated with them. This is up until 2003 in Myanmar, and you can see what an impact the large-scale preventive measures introduced in the 1990s and early 2000s made. With a focus initially on sex workers and drug users, promotion of condom use, and it's all linked to the slowing and promotion of HIV prevention. What is happening now, and this is in Thailand, and the same is happening in other neighboring countries, is you're seeing a slight increase in gonorrhea, syphilis, and also Chancroid. Programs have historically been particularly strong in Myanmar, but in fact, there's no data I can get on antibiotic susceptibility, which is increasing in Thailand, so that 0.5% of gonorrhea strains in Thailand are now resistant to ceftriaxone. And as I've mentioned, COVID has been the main reason for this occurring. Transmission can occur through bed linen, what are called fomites to skin-to-skin contact, genital fluid or mucous membranes to skin, and this is quite often how a primary chancre on the skin can occur because somebody is shaved part of their skin and then comes into contact with genital fluid. Blood dissemination, as occurs with disseminated gonococcal infection, where you rarely have any genital disease at all. Lymphatic spread, as I mentioned, with Chancroid and LGV. And those that are reactive to distance disease, like with what used to be called Riker's disease, there are skin rashes, you get conjunctivitis, you get arthritis, but it's important to be aware of these. Remember that primary genital disease may be asymptomatic and unnoticed or may be healed. So the common ones are scabies, which is not a concern, primary and secondary syphilis, HIV, and monkeypox. I'm not going to spend time on scabies. You all know about it. You all know how it presents, and you all know how to treat it. Cutaneous primary syphilis, just to make the point that you do get chancres outside of the genital and oral regions if that region has contact, has an abraded skin and has contact with genital fluid. And you can see in the lower picture somebody with a chancre on their abdomen as an example. Treatment is based on standard guidelines. Without treatment, they usually heal by 6 weeks. And then, of course, the patient can go on to get secondary syphilis. This usually appears 6 to 12 weeks from the time of infection, and in fact can overlap with the primary infection. You get this classic rash on the hands and soles, but over the body as well. It may occur anywhere, and it could look like anything. It's what's called the great imitator. Papules to plaques to pustules, with different lesions seeming to be present at the same time. It's often associated with fever and localized disease, iritis, neuritis, patients presenting with deafness, facial palsy, meningitis, septic meningitis. A classic skin rash you will have all seen, and a classic body rash, again, you will have all seen. This alopecia, they get what's called moth-eaten alopecia can occur, or somebody can completely lose their hair. You may get slightly unusual presentations, as this perioral annular patches and this hyperkeratotic plaques, again, features of syphilis. And in HIV patients, you get greater frequency and after exposure, and a quicker and more likely progression to secondary and tertiary disease. So what about monkeypox? It's a zoonotic pox which has been found in West Africa until 2022. And then since the beginning, really, of about April, May, it's been described in over 5,000 patients, if not more, in the West, Europe, USA, Australia. Transmission is by skin-to-skin contact, possibly by fomites, so bed linen, and possibly aerosol. 1 in 3 patients have underlying HIV when it's more severe. Classic triad is a rash, lymphadenopathy and fever, the rash occurring in 80%, 95 to 100%. It often evolves from a blister to a scab. Again, lesions occurring at different stages, and you see them at the same time. And palms 20%. The education is important to talk to the people who are most at risk. Post-exposure to somebody with monkeypox, you can give somebody smallpox vaccination as post-exposure prophylaxis, and there is an incredibly expensive drug you can use. I don't know where that red line came from, I do apologize, it's gone. And then the uncommon rare ones, tertiary syphilis, occurring years to decades after infection. You can get a gamma anywhere, but when it's on the skin, it's usually ulcerated and deep, painless, and it may occur in the bone, it may occur in the viscera. Treatment, again, according to guidelines, but it's 3 or 4 weeks of pen and probenecid or ceftriaxone or doxycycline. Disseminated gonococcal disease, people don't think about because there's rarely an STI presentation of the gonorrhea at the same time. It seems to be different strains. I've seen it only about 4 times, once with meningitis. But you get this pustule, a classic pustular rash, and you can identify the organism in that pus. Treatment is standard treatment. Ceftriaxone, as I mentioned, there is resistance in Thailand. Chancroid can cause skin ulcers. It's the same organism, Haemophilus ducreyi. it isn't associated when it causes skin ulcers with genital disease. They seem to be two separate things. It's seen particularly in Africa and the Pacific region. It can be seen in children as well as adults. It favors the lower limbs. A single dose of ceftriaxone or azithromycin will get rid of it. Then you've got this sexually acquired reactive arthritis, which is due to chlamydia trachomatis, but there are a host of other causes, usually intestinal causes. HLA-B27 linked, involving the lower limb joints, SI joints, causing tendinitis and conjunctivitis. Chlamydia can be found in the synovial tissues. Treatment is standard non-steroidals. If you identify chlamydia, then treat that. The unusual conditions you get, as well as the reactive arthritis, you can get conjunctivitis, iritis, you can get this very scaly rash usually on the soles of the feet. You can get nail changes as well, as you can see, and you can get abscess ulcers. It's usually self-limiting over 3 months, but it can go on longer. Then you've got the buboes. I'll be brief with these because I must have been talking a long time now. You've got chancroid, classic genital ulcer disease, which can cause a bubo. Treatment very straightforward, single dose injection. You've got LGV, which can be a very nasty infection. And this is a different serotype to that causes trachoma, causes chlamydia, genital chlamydia. It's serotype L, and it often leads to lymphadenopathy and bubo formation. Its late complication can lead to elephantiasis and genital lymphedema. And treatment is doxycycline or azithromycin, but complications can occur, which are severe. Granuloma inguinale caused by a bacterium, Klebsiella granulomatosis, is another cause of bubo, which just so in case when you're examining, you find somebody with bubo. I think you all know about the crab louse or pubic lice, and what to do about it. Obviously, general hygiene and removing the lice and eggs, but also malathion or permethrin. And scabies, I think, again, you've all seen, you know what to do about it. Chlamydia trachomatis of the eye, this is different in that it is not trachoma, it is the serotypes D to K, which are the genital lesions, and it's somebody who's self-inoculated from a lesion on their genitals into their eye, and it causes a very nasty follicular conjunctivitis. So again, treatment uncertain, just give scabies, you know, if you're certain about the treatment, give the correct treatment. If the syphilis screen is negative and uncertain whether the rash is linked to the cause of genital discharge or ulcer, give syndromic treatment for the STI according to your guidelines. And if no improvement, biopsy. There are always unusual diseases which you occasionally see. Annular lesion, which is anesthetic, think about leprosy. A winding track, considered cutaneous larva migrans. A swollen leg, consider lymphatic filariasis. And if you have a well-defined, rapidly spreading, painful, sloughy, indurated ulcer over the abdomen, especially in patients who has dysentery, then consider cutaneous amyloidosis. I'll finish there, and I'm sorry if I've gone on too long and I've hurried the last few slides. But thank you very much for listening.
Well, Ed, that was so fantastic, really a great refresher for the trainees in the UK as well as those in Myanmar. So thank you so much for your time. So now a few questions. So let me just bring up all the questions. So I've answered some of a couple of the ones that I was able to, which were questions on, dermatology related questions. So now, 3 categories really. One is about the HIV related questions specifically related to the art. So is lipodystrophy reversible?
That's a good question. I think it's fair to say it depends on how severe it is, but it's fat loss, and you can get a degree of fat recovery by switching early, but otherwise it's fat loss, and the only way you can actually treat it is to replace that fat artificially, either with fat transfer, but that doesn't tend to work, it doesn't last, or with a filler of some kind. But if you switch from D4T and put them on to tenofovir, you will certainly see some improvement. But if it's bad from D4T, it'll still be very obvious. So I would say it's partial, about 25% on switching to a drug that, an NRTI that doesn't cause fat atrophy.
Yeah. And in a way, you've got that window of opportunity to get in there early, I guess, as well.
Well, the key thing is that now we do not use the drugs that cause so much atrophy. And you use AZT, it's the only one we do use. We don't use D4T. We rarely use DDI at all now. And so it's only AZT. And as first-line treatment, it's tenofovir 3TC as the backbone for your NRTI combination in, an active retroviral therapy combination. So you're not seeing it anywhere near as much.
No, absolutely. So the second question is about, so I'm trying to understand the question, but please feel free to unmute yourself and correct me if I misunderstood your question. So I'll just read it out. In case, in the instance of patients with low VDRL low titer of VDRL dilution, for instance, 8 times dilution, how would you know the response to treatment when you recheck the titer? So I'm not quite sure what they're...
I think I do understand. It's sometimes you're treating patients, you've given them the correct course of treatment as according to guidelines, and yet the low titer remains. And sometimes it goes up and down a little bit. And I think if you have repeated this several times and it doesn't become negative, I would ignore it. I think all I would do is monitor it. And if it goes back up again, then you would need to retreat.
Absolutely, that's very
That's
helpful.
what whoever asked the question is getting to.
No, absolutely. So now moving on to the STIs actually. So I guess this is more of a sort of communication and the art of communication in a way with the patients. So how would you persuade the patients to test for another STI if the patient presents with another STI? So presumably, patients come to you with presenting with symptoms of the STI, but they probably won't want to have the test done because of cultural or various other barriers, and also having to persuade the partners to get tested or encourage them to communicate that to the partners. I think that's how
I think that for somebody who's got, say, a urethral discharge to come to see a doctor and want treatment without a sample being taken, that can only really happen in 2 situations. One, where the poor doctor has no facility to actually either look at the discharge or certainly to send it off for culture. And one just treats syndromically. Then I can see what one is doing is treating all the STDs that you can, bacterial STDs. And I'm assuming that when you have one, the doctor will say to the patient, you're at risk of having HIV as well. But in an ideal situation, a urethral sample would be taken and it would be looked at with a gram stain. It would be you'd be treated appropriately. A syphilis test would be taken, an HIV test would be taken. And so just going to the clinic and you would have a complete screen for the STDs. It would be impossible to go along and not have all the tests done as part of your MOT. Regarding persuading a partner, again, what one does is to firstly try and encourage the patient to persuade the partner, because that is the best way to do it. Otherwise, depending on the situation, but we have contact tracing, so that in a situation somebody doesn't want to let the partner know that he's had or she's had a sexually transmitted disease, but this really applies to HIV more than anything else, then there can be contact tracing by an anonymous source who can say a previous partner or this particular person has identified you as a previous partner and has been diagnosed with HIV, and our advice is you have an HIV test with actually naming the individual. So there is this alternative that you would really do for HIV. And I suppose the third option is to just treat the partner empirically, to give them some treatment. So if you diagnose somebody who has not syphilis, because you need to identify that, but if they have gonorrhea, then give them treatment to treat their partner as prophylaxis.
Yeah, no, absolutely. Thank you, Ed. So in the interest of time, what I might do is actually pick out some of the pertinent and clinically relevant questions. And
yes,
if that's okay. So one is about the, differential diagnoses, of course. So it's about umbilicated lesions. So perhaps, Professor Griffiths as well do chip in as well if there's any additional insight into this question. So how do you normally differentiate umbilicated lesions in HIV patients, molluscum versus Cryptococcus versus a few others?
I can cheat here. Somebody with molluscum is not going to be sick. Somebody with Cryptococcus, histoplasmosis, penicilliosis, they're all going to be terribly sick. So I think you're left with, has this patient got monkeypox, where some patients are not that sick, they just have fever. The critical feature of molluscum is the patient is well. They have spots. Even in patients with low CD4 counts, they're well. It's not a systemic illness. So I can cheat on the nature of the umbilicated lesion. But my limited knowledge of molluscum is that they are very well defined, quite deep vesicular lesion, which is umbilicated quite early. And if you have something like Cryptococcus or penicilliosis, the lesions are smaller and more fluid filled, and the actual covering is much thinner. That's a bad answer, but it's so easy to distinguish them because of the sickness, the illness.
Absolutely. No, you're absolutely right. I think, often people, there are spot diagnoses in dermatology, but then in a lot of the diagnoses we do take into the whole context. History is key to a
Yeah.
lot of diagnoses, as they normally are. But of course, you know, the art of visual literacy, as Professor Griffiths would say it, is also important. Now, 2 more questions, and I think we'll call it a day, but please send in complete the feedback. So Sue and Dr. Hinklegor have included in the chats. It's really important that we take on board your feedback so that we can provide you more tailored education in the future. So Ed, if it's okay, so 2 more questions. This is really important because I know from our dermatology colleagues that they are seeing a lot more antifungal resistant tinea. So what is your experience with resistant fungal infections in the context of immunocompromised patients?
Well, that's a difficult one. The situation I've seen really nasty fungal infections, of course, has been in Myanmar. And we had a limitation of drugs. And so not even terbinafine. Now, I'm assuming that we're talking about drugs, patients who have such severe tinea infection, it's not responding to terbinafine. Is that correct?
I would imagine so, yes.
I have this horrible feeling that the amphotericin is not active against tinea, and one would be looking at some of the other antifungal classes to be treating it. And I'm not going to try and hedge my bets here. I would have to check on what the correct answer to give you is, because it's sometimes I've treated a very bad tinea infection. I'm going to pass on that one.
I understand that the dermatology department in Yangon is using voriconazole at the moment, and yet they are still not sure how responsive. But I'll stop it here, actually. Thank you so much, Ed. And
I mean, I could just say voriconazole does have a slightly different spectrum. Not come across it in that situation, but you can give it, of course, intravenously, which is a benefit, as well as orally. But at the end of the day, it is an azole, and one is therefore giving a sort of Ferrari version of itraconazole. So I'd be surprised if it has wonderful results. But I'll check it when this is finished.
No, absolutely. Thank you so much, Dr. Wilkins.
No trouble at all.
And Professor Griffiths, whether you have a few words that you wanted to add.
No, I just want to thank Dr. Wilkins on behalf of all of us for such a fabulous lecture. I mean, this is such a host of practical information in 45 minutes. It was really spectacular. And I'm so pleased we've got the PDF to share as well, because there's a lot of detail in there. And, you know, this is an evolving area, isn't it? You know, monkeypox, the resistance of tinea now. So, you know, this is constantly changing. So thank you for such a great up-to-date lecture, and we wish you all the best with your house move, which I think is tomorrow.
Yes, it is the focus of my attention at the moment. Yeah, thank you, Chris. Thank you, Sue.
Yeah.
I'll speak to you,
so
I'm sure.
Okay,
Speak to you
take care.
soon.
Very much, Ed. Thank you very much, Chris.
Thank you.
Bye.
Cheers, Martin. Bye-bye. Minglava.
We're going to go poll.